So it's great. It's a great segue into like the next question is like is the treatment approach, right? So we've been talking about here is the surgical approach, and obviously the alternative approach would be to go with chemotherapy first in the neoadjuvant fashion. So Susanna, maybe you could give us a little bit of an idea of where that data, what that literature is telling us
So,
about now.
by definition, we have a stage 4 ovarian cancer at this point in time. And I'm kind of, we've had many different studies in terms of neoadjuvant therapy versus adjuvant, the ERTC, the CHORUS study, the JCOG, and of course the Scorpion trial, and soon hopefully to be the true test, which will be the TRUST data coming up, I hope. But, the ones that we've concentrated on the most have been the ERTC and the CHORUS data. And, just, recently published in The Lancet in 2018 was Dr. Virgo's kind of it's a pooled analysis of both the ERTC and the CHORUS. And it was about 1,200 patients. So it was a sizable group of individuals. And, they looked at the data, and the end result didn't change very much in terms of that, neoadjuvant therapy was really similar to that of primary debulking surgery in the group as a whole. But, they made some actually very important comments in terms of patients had, 3 centimeters and less than 5 centimeters extrapelvic disease versus, stage 3 with greater than 5 centimeters extrapelvic disease. And they made some distinctions as to, which patients really would do better with primary debulking surgery. In the study, it's 1,200 patients, but only 19% really had stage 4.
Right.
But even in that stage 4, and granted it's 19% of individuals, if you looked at median survival, the median survival was better with neoadjuvant therapy in stage 4 in that particular review, about 3 months. And so was progression-free survival. So one can be mindful of that if in essence you truly believe that this, and it, as written, is a stage 4 ovarian cancer.
So Dave, what's your experience with the impact of neoadjuvant therapy on surgery?
It's pretty clear that you're going to have less bowel surgery, less colostomies, less ICU admissions, less blood transfusions. So, when we're really looking at those patients, it clearly is going to be a less morbid surgery. I always talk to my fellows about, but it's always tougher than you think it's going to be.
Yeah.
You have a bunch of fibrosis.
Yeah.
You end up digging off the omentum for forever and trying not to do the transverse colectomy. And so, I think that's a really important aspect that it's also, but it's not chip shot surgery.
Yeah.
Now, one thing you just brought up, I think is, again, one of the most underquoted statistics is less than 5 centimeter disease, particularly if it's isolated. Those patients did significantly better in a primary debulking.
Right.
So identifying those patients who we shouldn't be operating, but on the same side, identifying those patients who we should absolutely be operating.
That's right. Right. So let me ask you, one of the prerequisites of the 2 neoadjuvant trials is they had to have some convincing evidence that the path wasn't non-GYN, that it was GYN, the negative there. So, and so what kind of things can we use to help convince us that this biopsy we took of the omentum is actually ovarian cancer?
But actually, in a follow-up of that, not that long ago, we would do cytology of the ascites and thought that was good enough.
Right.
Now, I think we definitely need, do we need core biopsies on these or FNAs or what?
I think we'll definitely get to that. I got on one of the other cases, I want to bring that question up. So thanks for bringing it up. But if we have a specimen, let's say somebody to biopsy the omentum, and they, how can you convince us that it's a Mullerian origin?
But there's certain markers that we kind of touched on, like the PAX8 that seems to be, it's positive, I guess, in thyroid, but and some kidney, but it tends to be mainly positive in Mullerian, but especially with the so-called high-grade serous, really it's one of the diseases that's defined by a specific molecular alteration where all the high-grade serous have P53. So if we, with the immunohistochemistry, if we can feel confident that it's going one way or the other, that it's all the cells have the high expression of P53, or it's the complete null, that certainly goes with the.
What about for mucinous? Because we see this in mucinous cancer as well. Same kind of disease distribution, but the markers are a little different, aren't they?
Yeah, I guess I'm not as familiar with how that would be different.
Usually, from what I understand, like the CK20, 7, 20 are helpful.
CK20.
And the 20s
can be helpful.
Can be.
Not
perfect.
And the other thing, just to be fair, on the trials, the way we did it is we also kind of broke down the CA125 CEA, and they had a ratio of 25-1, and so that was kind of another piece. So we do our best. Sometimes we're wrong. Even in the study that we did, we found about 10, 11% of the times we were actually, when we did the scope and got tissue biopsy from the ovary, we were actually wrong. it was actually a non-GYN
But I
primary.
think if you use that criteria, you can be fairly confident that you're treating a Malarian or GYN primary.
Yeah. And I would guess of this disease types is probably the better one, to, at least
Benefit of the doubt for the patient.
potentially, yeah, for some response to therapy.